Welcome to Redefining Medicine, an intimate and personalized program that illustrates a different side of the practice of medicine. Our in-depth conversations will focus on the physicians and practitioners who are redefining medicine through their integrative, functional, and holistic approach to health and well-being.
We are pleased to welcome Dr. Neil Nathan, a board-certified practitioner of nearly 5 decades with an acute focus on chronic, complex medical illnesses. Welcome.
Thank you.
Will you share what attracted you to the study of chronic, complex medical illnesses?
Well, early in my career, I got really interested in the patients who were not responding to what I did. It was fine having people who responded well to conventional treatment, but I was just fascinated by those people I couldn't help. So I began to study a wide variety of alternatives to see if I could help them. As my career unfolded, I began to use those to help some of those patients. And so my colleagues began to refer more and more of these complicated patients who were not responding as one would have expected to conventional medical care to me. And I found I had to learn more.
When you started out in medicine, what was your area of focus?
Oh, I started out as a family physician so that I was delivering babies. I did a little bit of surgery. I was the head of the emergency room in the little community I practiced in, basically seeing pretty much everything. Over time, I got more trained in and good at treating chronic pain. So later in my career, I became a chronic pain specialist, ran hospital-based units, again, specializing in trying to diagnose and help people that my colleagues weren't able to quite figure out.
Right. And what was the kind of this standard approach back then? Was it all like pharmaceutical based?
Yeah. As an example, one of my first partners in medicine was a chiropractor. And I would see patients with back pain and neck pain come in to see him, and they'd leave his office pain-free. And I would be using codeine or muscle relaxants. We didn't have a lot in those days, and it would take them 10 days to get well. So one of my early experiences was going up to him and saying, "Can you teach me to do what you do?" And he was a little bit skeptical because in those days, chiropractors and doctors didn't communicate or associate with each other very much. But he taught me some very basic manipulation, and that motivated me to actually train in osteopathic manipulation so that I began to add that tool to what I was doing. And I found I could help a lot of people that my pharmaceutical approach didn't really do much for.
Right. And then you started to get a reputation for being able to help some of these complex cases, and I imagine you got a lot of referrals.
Right, I did. And back in the 80s, we began to see a condition that we did not understand, which we called fibrositis, which we now call fibromyalgia, where people had multi-system illness, fatigue and pains all over the place, sleep difficulties, that it made no sense to us. It was kind of like a creature we hadn't seen before. When that happens in medicine, the first thought is, oh, it's psychological, because nothing really explains all of that. But those patients didn't respond well to psychotherapy or psychotherapeutic drugs. And over time, we became interested in how do we help those people, and slowly evolved a whole menu of imbalances, deficiencies that those patients had that we could actually treat. And as a pain specialist, I did that a lot. Eventually, with fibromyalgia and chronic fatigue, which I was seeing a lot of, we realized that, oh, some of those patients have Lyme disease. Later, oh, some of those patients actually have mold toxicity or other environmental toxicities. So this evolved into my current practice, where again, I'm kind of a medical detective working with patients that, again, are a little bit baffling to my profession, looking for things that they might consider obscure, but in my world is actually quite common.
Right. I know that anti-aging functional medicine uses a variety of tests that are not typically used in conventional medicine, but really help you to discover things like you're talking about. You rely on a lot of lab testing, I would imagine?
I do. We use lab testing to look for mold toxicity. We use testing for Lyme disease and other infections. And we also test for various hormone imbalances, which are extremely common in those patients. And some of those tests are not typically conventionally used because those of us who've been studying this for a while have realized that it's more complicated than we were taught in medical school. And you have to dig deeper and look harder to get to the root of those imbalances.
Mm-hmm. And some of these might be food sensitivities and food allergies. I imagine you do micronutrient testing and things like that?
Right, those are extremely common in all of those patients, yes.
Let's talk a little bit about your books.
Okay.
Your latest book, titled Toxic, examines how mold toxicity, Lyme disease, chemical sensitivities, and chronic environmental illness affect a patient. What are some of the greatest clinical misconceptions surrounding environmentally acquired illnesses that you would like to address or clear up here?
Well, first of all, they're underappreciated. The more we do this work, the more worried we become that the pollution and the chemical toxicity of our planet is becoming dangerously high. We see that in the epidemics of chronic fatigue, fibromyalgia, neurodegenerative disease, autism, cancer. The rates of those illnesses have skyrocketed in ways that make no sense unless we begin to understand that this is toxicity and of what we're being exposed to on a daily basis. And as that realization began to hit us, the book Toxic is really about how to help the most sensitive and toxic patients that I see. And I now get referred those by most of my colleagues. Many physicians are beginning to see more and more patients where they can't take a tiny drop of a homeopathic. They can't take a tiny amount of a binder for mold like chlorella or clay or charcoal without having a severe reaction to it.
Wow.
And that's been kind of hard to understand in my profession until we begin to understand it as a rising amount of toxicity that needs to be treated and a rising amount of sensitivity, because those toxins affect certain brain areas that make the patient sensitive. And the book really is intended to help both patients and physicians understand what are the most common conditions that cause that, so that then they can address treatment in a much more comprehensive and effective way.
Mm-hmm. And these toxins are really everywhere, like even in this room where we're seated, the fire retardant material that they use in the chair or in the ceiling tiles or the carpeting and such are off-gassing, and we're breathing this stuff in all the time, right?
Yeah, ubiquitous. It is all around us. In the last 50 years, we've introduced perhaps 70,000 chemicals into our environment, mm-hmm. and of that, maybe 5% have been examined for their health consequences. Wow. So we're being bombarded by materials that have never been tested, no one knows much about, and we've taken it for granted that somebody is looking at that for safety. Right. And that's not happening.
And long-term effects of this buildup in the body.
Correct.
So then your approach is to test and see what levels and what kinds of toxins are built up in the body, and then try to eliminate them through what, diet, chelation? What's your approach?
Correct. The most common of the toxins we now believe to be mold toxicity. Mm-hmm. Mold toxin readily grows. It's estimated that maybe 50% of all buildings in this country are mold toxic, and that's especially true of office buildings, schools, where people don't have the money to remediate once there's been a leak in the ceiling or water damage in some area. So it's extremely common. Estimated maybe 10 million Americans have some form of mold toxicity, mm-hmm. and under-recognized. So looking at things like mold toxicity and Lyme disease are key. They're the most common. The problem with other chemicals is we don't even have tests for them yet to even know what other things are you being exposed to. So treatment involves as specific as we can for mold, but adding to it, improving the body's ability to detoxify generically so that it can help to eliminate those materials. It also involves really paying attention to what you drink, the quality of the water, what you eat, your food, particularly eating organic, is extremely important. There are many studies showing that the quality of organic food is profoundly better for you than non-organic food in which many toxins accumulate.
Mm-hmm. How about exercise?
Exercise is healthy for everyone. Highly recommend it. Sweating is a good way to get rid of toxins, though, so from that perspective, that's very helpful, as would be saunas, hot tub, taking a hot bath. All of those are helpful.
Right. Why are some people more sensitive and prone to chronic illness because of toxic exposure than others?
Well, that's a complicated question, but the simple answer is, first of all, everyone is uniquely biochemically and genetically different. So we estimate that perhaps 20-25% of patients, for example, are susceptible to mold toxin, while others are not. The same is true for other toxins to different degrees, again, depending on your genes and your environment, how cleanly you've lived, how lucky you've been to not be in moldy or other toxic environments, and the amount of exposure varies, so that if you have unwittingly been in a moldy building, I mean, I can't count the number of patients who said, yeah, when I was a kid, I lived in the basement and there was black mold growing all over the place, but nobody thought that mattered. And well, we now know different.
Right, right. We also know that prenatal babies, in the mother's cord blood, there's hundreds of toxins. Do you know what that statistic is? I've heard it before.
Yeah, something like 280 of the ones measured. So it's terrifying to think that virtually every baby in this country has over 200 measured toxins already being delivered to them before they even get out into this world. And that's only the ones we measure. One of the things about that study is, think of the other tens of thousands of chemicals that we don't even know about. So little babies have a rough road. They're coming into a toxic world, and we are not appreciating it, and we really need to get on that.
Yeah. Do you work with politicians and any research groups or advocate for environmental issues?
Shockingly, despite some lip service, the government puts virtually no effort into evaluating these chemicals. And again, from an economic, political point of view, there's not much of a push to eliminate all of these chemicals because the industries that make them are not particularly interested in having anyone do this research or learn more about it.
Yeah,
so the public's going to need to mobilize that on its own. The public's going to need to talk to their own congressmen and senators and say, this is actually approaching a national travesty. We really need to do something about it.
Right. And books like yours are raising the public awareness of these issues, and hopefully that's the net effect.
That's my hope.
Yeah, I would imagine. You led a presentation here entitled The Role of Mitochondrial Dysfunction in Chronic Disease, the Cell Danger Response Model. Can you talk a little bit about that?
Sure. The cell danger response is a model proposed by Dr. Robert Navio, who is a professor at the University of California in San Diego and has been studying the chemistry of children especially for his whole career. And over the years, he put together a fabulous model or way of understanding all chronic illness. And basically what it consists of is the mitochondria, which many of us know are the little factories in our cells that make energy, also are monitors of safety, so that if a mitochondria notes any possibility of threat from a toxin or from an infectious agent, it automatically shuts down the cell in a very organized, proscribed, orchestrated manner. And those changes ultimately begin to turn into chronic illness if the body doesn't feel like it is safe. So that at a cellular level, translated into a body level, If that cell is not convinced that the infection is gone or the toxin is gone, that threat persists, and then all of those biochemical changes become chronic. So what I did in that lecture was to go into detail about what those changes are, how we can understand them, how that helps us to understand chronic illness, and especially important is when that happens, patients in which we measure deficiencies, let's say they're not methylating, let's say their magnesium is low, let's say we know their mitochondria aren't functioning. Well, of course their mitochondria aren't functioning. That's the organelle that's telling us that we've got a problem. So the normal strategies that we would give to treat those conditions don't work until that cell danger response is quieted down. So part of the important clinical component of that information is to tell us, I've got to work harder to quiet that down so that my patient can respond to the things that are going to get them well later. If I try to give it to them before they're ready, it just doesn't work.
Mm-hmm. Yeah, and that's great information for this particular audience and the A4M membership, because this group is all about root cause of disease and not just symptom management,
right.
but having the tools to understand what is the root cause of chronic illness. Your career spans nearly 5 decades with various roles, including serving as a medical director, emergency room director, professor, and private practice physician, among others. What changes within healthcare do you find most striking when you look back at when you first began?
Wow, medicine has changed amazingly, and to say it in terms of 5 decades makes me feel old. Sorry, I guess I am old. Well, those changes are massive. I started practicing medicine in what some people call the golden age of medicine, which was fee-for-service, where someone could come in and I treated them and they paid me. And over the next 30 years, we then began to see the inroads of HMO-type care, in which the model of medicine had changed from a relationship that I have with my patient, I provide care, they pay me, to somebody else who is in an administrative capacity tells me as a doctor what I can or can't do for my patient, which from my perspective was unacceptable. Now let me get this straight. I'm seeing the patient, but you will tell me what I can order or I can't order because you want to save money. And if I can be nasty about it, those people making those decisions are making huge bonuses at the end of the year for doing so.
Yes.
So that shift in medicine was both profound and the wrong direction. And then it got into productivity. So you've got to see patients every 7 minutes in order to keep up your productivity and make us money. And I grew up in an era where I don't know that I can accomplish much in 7 minutes. And in the work that I do now with very complicated, difficult patients, I'm barely learning their name in 7 minutes. So I could not practice that way at all, doing the kind of medicine that I do.
And then hospitals in the 70s went from nonprofit to profit, right?
Right, and I did hospital medicine as a family doc. My patients who I knew came into the hospital and I took care of them. If I needed consultation, I got it. But medicine now is primarily done by hospitalists, where someone who doesn't know my patient at all will take over. They have varying degrees of interest in the information I want to give them. It's kind of disappointing that if my patient goes into the hospital, I can't remember the last time a hospitalist called me and said, you know the patient, tell me about him. What's going on with him? What should I know about them? What should I be doing? They never call. They're so busy that they're just almost triaging the patient in a hospital situation, so that hospital care has decidedly gone downward in every way conceivable. And then we have the understanding of medicine, which is the chronic illnesses that we deal with, that A4M deals with. We're trying to understand that in a way that conventional medicine currently does not. The model for that is an acute care model. You have a sore throat, you get a throat culture, we give you penicillin, you get cured, we're happy. That's beautiful. Well, because of all the toxicity of the world we live in, the people we're seeing now are much sicker than they ever were. I never saw people like this in the early years of my practice, partly because they're getting referred to me, but I think that this is generalized. I think that almost all physicians would be telling you, I can't deal with this. It's more complicated than I deal with, so I refer it to specialists who work out of a certain boxed area, and they go not exactly in my arena, and the patient gets sent from physician to a physician. They don't get diagnosed, they don't get to the core of their illness, and they stay sick for a long period of time. And that's a generic hit on my understanding how medicine is practiced now, which I'm ashamed and embarrassed for my field that we have gone in this direction. We really have not done right by our patients, and especially by the structure that we have accepted that's been imposed on us.
Right. Things need to change.
It needs to change.
Yeah, yeah. A closing thought, what would your main piece of advice be for a practicing physician today? Perhaps a conventional or somebody that is in anti-aging functional medicine with regard to what we were just discussing?
It's simple. Be interested in your patients. Study, learn, go to more meetings. Not necessarily the meetings that you would have gone to where you reassure yourself that, yes, I know how to deal with liver issues or heart issues, but go to different meetings. Learn another model. From my perspective, integrative medicine is the medicine of the future. It's what medicine should be. And we used to call it alternative medicine, and I hated that term because I never thought I was an alternative. I thought I was practicing the way all doctors should be practicing. So for a young doctor starting, there's a tremendous amount to learn. Follow your intuition and heart. Start somewhere, learn more, and as you find that you can help more of your patients, you'll be motivated to learn more, and it becomes a lifelong learning experience, really being happy with your field that you are helping more and more patients all the time.
Great advice. Thank you for sharing your wisdom with us today.
You're welcome.